So, hello and welcome. Good morning to our colleagues from Asia. Good evening to those joining us here in California, and welcome to all of you from all over the world, perhaps seeing our recording afterwards. Welcome to our webinar today. My name is Karen Eggleston. I'm director of the Stanford Asia Health Policy Program, and I'm delighted to welcome you today to our special webinar commemorating 3 decades of universal health coverage in Taiwan. There's no one better to talk about this topic than our expert joining us today. My privilege to introduce to you Dr. Hongjen Chang. He is currently chair and CEO of YFY Biotech Management, in addition to serving as chair for several other private biotech firms. Before joining YFY Group, Dr. Zhang dedicated over 16 years of his distinguished career to Taiwan's public health administration, including leading the single payer institution in Taiwan. He also led Taiwan Global Biofund. He's well recognized for his public administration experience, especially implementing the Smart Card program in Taiwan, which is cited for many things, including being crucial to Taiwan's success in managing the COVID pandemic. Dr. Zhang holds a medical degree from National Yangming Medical College, a master's in public health from National Taiwan University, and a master's in health policy and management from Harvard School of Public Health. And after he gives his remarks today, we'll have time for some questions from you, our audience. So please put those questions in the Q&A function on Zoom, and we'll get to as many of those as we can after he's introduced the topic to us today. So Dr. Zhang, we look forward to your sharing your insights about achievements and challenges in this 30th anniversary year. Over to you.
Thank you, Karen. Hi, everybody. I'm very, very honored. And actually, I was very surprised to be invited because I haven't talked about this topic in English for many, many years. Hopefully, you will learn something from this speech. The outline is that what happened in 1995 and the initial results, what was everybody see Taiwan's system, and what are the challenges after 30 years of success, and how can we learn from Taiwan's experience? I asked ChatGPT, so this is what happens in the world. Okay, you know, the Middle East is always turmoil. Microsoft just launched Windows 95. It seems like Stone Age to our much younger audience today. And both the US and Japan experienced the first domestic terrorist attack. and the launch of the dot-com era. And by the way, Google was not born yet. So you know that's 1995. Okay. And in this part of the world, Taiwan just moving from an authoritarian regime to full democracy. So we have the first direct presidential election in 1996, and China was not happy about that, so they launched two missiles to our nearby seas, and the U.S. was helping by sending the aircraft carriers to this part of the world to stabilize the situation. Okay, so Taiwan is here. Okay, and at that time, most people thought we were Thailand. Okay, but nowadays, I think Taiwan is much more famous. We were a middle-income country and with very decent public health record. And what did we do? it was actually very, very surprising. So if you look at this line, this is 1995. So before March 1st, 1995, only about 60% of the population was covered by any health insurance. And most of the uninsured are the mothers, children, the retired person or the unemployed. So it's mostly the most vulnerable population which was left behind. And we did it overnight. So we legislated that starting March 1st, 1995, everybody will be covered. And just make the story short, this guy, Dr. Ye Jinchuan, also an MD and MPH, MD from NTU, MPH from Harvard, who did this. If you want to know the whole story, you need to read his book, but it's in Chinese. But you don't need to worry. Nowadays, ChatGPT can do the translation for you. So in the beginning, in short, the benefit packages are very comprehensive, except long-term care was not included at that time. So we include dental service and Chinese medicine also. And the system is free to access. You can go to any doctor, any hospital at any time you want with very minimal co-payment and cost sharing. So after a couple of years during my tenure, I asked my mentor, Professor William Shaw, to see if he can do something to assess the system. So he and Rachel Liu co-authored this paper, said, does universal health insurance make healthcare unaffordable? Surprisingly, their conclusion is that we were able to adopt the system without using measurably more resources than you would have spent without the program. So this is a very surprising outcome. We extend protection to some 40% of the most vulnerable population without using more resources. And if we look at the outcome, some experts in Taiwan at that time using life expectancy and concluded that NHI was useless, so to speak. But Professor Liu Yuchun, using a minimal mortality, separate that non-amenable and malignant, and concluded that yes, for a minimal mortality, NHI was very important to the improvement of the health of the people. And this paper I co-authored with Nicole Huang, that if we using a surrogate and rupture appendicitis as a surrogate indicator for timely access to care. In Taiwan, we do have remote areas. We have very high mountains, and many Aboriginal people live there for centuries. And we have some islands in the Taiwan Straits. So physically, it's very difficult to access. But after a couple of years of NHI's operation, we implemented a system that everybody have full access to care 24 hours a day. So the data is very convincing that these remote islands have the same rupture append in the most of the other places. And we did, from the beginning, we did consistent, we surveyed the satisfaction of the people. So as I said, in the beginning it was chaotic, but Dr. Ye Jinchuan, who was considered an Iron Man, he he have climbed every the so-called 100 peaks above 3,000 meters or 10,000 feet above sea level in Taiwan. So he was considered Iron Man. So he did it in 6 months. So in 6 months, the satisfaction rate approval rate already exceed 50%. And my tenure was from 2001, from here to here. During my tenure, we did the first so-called double raise. We raised the premium and raised the co-payment, although only perhaps some $5, $10, or $20 US dollars for premium for most people, and a couple of US dollars for copayment, but but the satisfaction rate plunge and then recover. And then after a couple of years, we now reaching more than 90%. It's crazy. So at the 10th anniversary, I was invited. I already left. I was invited to give a talk at that symposium. And these are the slides from 20 years ago. So for most of all the indicators I used, universality, accessibility, affordability, efficiency, satisfaction, quality. I think uh, we achieve very high marks, except that from day one of the system, willingness to pay has always been a problem for us, and we'll come back to this point later. And I concluded that it was a success in the first 10 years, and the possible factors I attributed to single payer system from the insurance side, full competitive market on the delivery side, and we invested heavily from day one on information technology. And Taiwan already have a very strong generic pharmaceutical industry at that time. And we had family support. That's our culture. And doctors and nurses are working very hard. But I put a question mark for this talk because I think it's no longer true today. So it is possible to establish a system to extend population to all without incurring more cost. The rapid extension, I believe, was unprecedented. And we studied almost all the major systems in the world before coming up with our own. And I personally believe that visionary investment in information structure was critical. So this is a smart card, which I delivered to all our people in 2004. And the late Professor Uwe Reinhardt, I believe many of you may know him quite well. He came to visit us in 2008 and wrote this article that said "Humboldt in Taiwan." Literally, you cannot read it. You need to read the paper. Literally, he said that American insurance company would be lucky to know how much they spent last year, 6 months after the end of the fiscal year. And Taiwan, at that time, we know how much we spent yesterday. So that's the huge difference. Because of this and that, when the PBS frontline, they wanted to do a special on sick around the world, Taiwan was selected. This was Tom Reed. He later wrote a book, and this was a much younger me. Okay, this is Chiang Kai-shek Memorial must visit place in Taipei City. So I think the good news perhaps is about to end. And so when Professor Paul Krugman, the Nobel laureate, visited us in 2014, he wrote something in New York Times, I believe, and he questioned that. He said, is Taiwan's healthcare system still a health utopia? And the next year, a local magazine did a huge survey on some 9,000 doctors, nurses, pharmacists, and more than 90% of the respondents are very pessimistic about the future of our healthcare system. So when we enter the 2020s, the first thing we know is COVID-19. And we did very well, especially for first some about 18 months from 2020 to early 2021. We registered, I think, the lowest excess mortality rate in the world. economy is still moving. People are free to enjoy their life in Taiwan. So on the face of it, the system responsiveness to such pandemic and resilience seems quite still holds up. So that's that's 2020, and geopolitically, I think nothing seems to change, and we were nominated as the most dangerous place on earth until Russia invaded Ukraine. So we lost the first place, and I don't know what could happen. And this time, I think United States is not very helping. Okay, so if we compare now and then, in 2024, we are already a high-income country, so we are richer, we live longer, but we get much older. Okay, and if you look at how much we spend, this is Taiwan comparing to OECD countries. We spend only 6% of GDP on health. That's quite low. This statistic does not include long-term care. This one does include long-term care. So we are spending around 7%, but comparing to other social insurance countries, we are very low, especially comparing to Korea. You can see Korea this line, and Taiwan this line. So sustainability of our program at such low level of expenditure, is that sustainable? You can see that we are aging and we are have extremely low fertility. And as people age, we have the burden of chronic diseases and multi-morbidity. And as we get richer, we have high demand and expectations, and the costs are rising. And willingness to pay constrain our ability to finance. And I believe many of you are familiar with this paper by Joseph Newhouse. Income, insurance, and technology are the key driver of cost, and we have all of it. So look deeper into our problem. We have workforce shortage, especially after COVID-19. This is the picture of the most prestigious hospital in Taiwan, the National Taiwan University Hospital, sitting at the center of Taipei City. This is the lobby. Entrance is this direction. Emergency room is on the far corner, and you can see the beds are overflowing into the lobby. And this photo actually has lots of response of the people, because we have shortage of nurses, and this nurse is still on duty. Okay, and it seems that the financial protection of the people are diminishing. If you use OOP as percentage of the current health expenditure, is quite high. It's about more than 31%. And if you look at specific disease category, so this is a study done by Professor Nicole Huang on breast cancer patient. You can see that out-of-pocket cost, primarily the drug cost, is very high. The good news is people are from very early days, some from the beginning of NHI, start to purchase supplementary commercial health insurance policies, and the coverage rate is about 70% of the total population, and policy per capita is quite high. It's approaching 5 per capita. But the bad news is that households with catastrophic expenditure is increasing. If you really want to understand what's happening in this area, Professor Christy Poo published this paper just recently. And because of this low level of financing, we have delay in new technology and new drugs. I just give you this example. This was done by Taiwan Cancer Foundation back in 2023, saying that the average time of a new drug, cancer drug, receiving NHI coverage after Taiwan's FDA approval are so long, it's more than 2 years. And the percentage of covered indication of FDA's approved label was nearly 30%. So the adoption of the new technology and new drug has been a problem, especially in recent years. And as a result, you can tell that although in 2020, in 2020, where is my cursor? In 2020, we were living in paradise, but then after Omicron, the system are capacity cannot live up with that with that Omicron and infection of COVID-19, and then we need to pay. So actually, this is a large dip of life expectancy for decades. And if you look at healthy life expectancy, comparing to Japan, Singapore, Korea, these are the three countries which in East Asia we have more or less comparable economic and public health system, which we rank the lowest. If we look at amenable mortality, which is a better indicator, Taiwan still rank the lowest among these social insurance countries. And I also believe that you are familiar with this index, the HAQ, Health Access and Quality Index, mostly is using minimal mortality to rank countries. Again, we rank the lowest with neighboring countries. So beyond the early success in Taiwan, I personally believe that prolonged very stringent cost control, we have a system called global budget, but today I don't have time to explain it. So we just talk about the result. Put the sustainability of our system at stake. So what's our problem? For one thing, we already is a high-income country, and the economy is very strong because of AI. But our healthcare expenditure comprise only 7% of GDP. At this low level, why we are suffering from chronic underfunding? The key seems to be people's belief that other people are abusing the system. Whenever we did survey asking people who are abusing the system, 90% of people said, not me. Other people are abusing the system. And so they think there are lots of waste in the system. And so it leads to a very low support. Whenever we want to raise premium, it's like a political warfare in Taiwan. You cannot imagine that. And finally, sustaining extremely high satisfaction rate makes any major reform very difficult, if not impossible. I use this graph to explain. Here, collective WT willingness to pay, meaning people's willingness to pay into the pool of NHI. And individual willingness to pay is that people to pay for themselves, especially via private health insurance. Ironically, actually, this is more expensive than this, but people prefer this over this. Interesting phenomenon. So 30 years ago, we kind of forced. I use this term because at that time it was President Lee Teng-hui's personal determination to put NHI to the people. Okay, so it's not a truly, because it was not fully democratic yet. So it's not a truly democratic process, not bottom up but top down. So I said people were forced to pay for others, meaning paying into this NHI coffer, and created a high performance system. Now people prefer to pay for themselves, and well, they are paying more, and the equity, less equity, and worse outcome. Strange Taiwanese people. So what are the lessons learned? Strong political commitment and leadership is the key to the success, and also to the continued improvement of I believe, any universal health care system. And investment in information technology infrastructure will definitely be very rewarding. Sustain low level of expenditure, such as Taiwan's case, is detrimental to health and quality of care. And I use tragedy of the commons to describe the situation where when people maximize their own preference, actually the collective outcome is worse. And the very strong political leadership which we witnessed 30 years ago seems unrepeatable nowadays. Okay, I need to thank these three lady professors, especially Nicole Huang. She actually helped prepare uh, uh, most of the slides I use. Without them, I cannot make this speech. And finally, before I I thank you for your attention. I wrote two books for the public. And it's all in Chinese. Okay, recently from 5 years ago and 2 years ago, to comment on the system. So if you are interested, it could be available online. And again, you can use ChatGPT to translate that. With this, I thank you for your attention. Thank you very much.
Well, thank you so much for that concise overview and all of your experience. So the floor is open for questions. Thank you for putting your questions in the Q&A. We'll start with some of those. So Dr. Zhang, you mentioned a competitive service delivery system, I think, as being part of the foundation. We have a question here. How does the private health sector contribute to UHC in Taiwan? And does the government have specific policies encouraging or related to the balance of public and private, for-profit, not-for-profit, and so on?
Yeah, this is a extremely important question. Okay, actually, we need to go back to pre-NHI era. So in the 1976, Taiwan, a private company in Taiwan built the first major private not-for-profit hospital, the biggest one, the Chang'an Hospital. So that's the transition. Before 1976, 80% of the hospital beds are public hospitals. And most of the public hospitals actually were built by the Japanese a century ago. Okay, and in the 1970s, the conditions of the hospitals are not good. And in 1980s, the government decided to have this encouraging the private, and also put money into the renovate the public hospitals. So we spent some 20 years before we start, before 1995, to transition an investment to increase our supply of hospitals. So in 20 years before 1995, 70% of hospital beds are owned by private, either for profit or not for profit. So this is a major transition. That is why we can have a delivery system which I describe as highly competitive. So everybody is competing with everybody else, including the public hospital. Did I answer the question?
Yes, thank you. Thank you.
You're welcome.
So yes, thank you. So another question, you mentioned with and without long-term care. So other economies treat long-term care in different ways. As you know, Japan and South Korea have a separate long-term care insurance system. Um, do you have any thoughts about how long-term care relates to NHI in Taiwan?
We were a kind of latecomer of long-term care. One reason perhaps the NHI has been doing too good. Okay, and the population was much younger, you know, 20, 30 years ago. And as I said, we still have very good family support. So it's not until I believe it's perhaps 15 years ago that we started to think that maybe we should put some long-term care in it. And nowadays, long-term care is a indispensable part of the whole journey of the healthcare system. But we have our own problems. So the two systems are not very fully integrated. So it's not working very smoothly until recently.
So if there are any other questions, you can add those to the Q&A. I'll jump in with some of mine. So um, in healthcare and in long-term care, in many economies, there's a presence of um, immigrant labor. You mentioned workforce challenges, and I don't know if immigrant labor is important in certain niches of the system or what your views are on how that plays a role in issues of workforce in the system.
Immigrant workforce is extremely important to Taiwan nowadays, not only in the manufacturing sector where we rely heavily on many of the immigrant workers from Southeast Asia, but also the domestic helpers. And the domestic helpers, in the beginning, uh, even before last year, we restricted the availability of these immigrant workers as domestic helpers. These helpers are very, very important for older people, especially those chronically ill, especially when any family member has a major health event. And our hospitals have a shortage of nursing staff. So usually you need to have somebody to accompany uh, the patient in the hospital to take care, uh, to help the nurses take care. So immigrant workers important in two ways. But we do not uh, have a policy to allow or register nurse as immigrant workers. So this is not open yet, although we already have a shortage of nursing power.
Another question, how much of the insurance fund has been accumulated due to reduced use of medical services during and after the pandemic, the COVID-19 pandemic? And this questioner is asking, would that reserve fund be helpful in implementing the more equitable coverage policies that you mentioned?
This is a very good question, but uh, the reason for this question is that I did not explain one uh, critical but very complicated system that Taiwan has been using since 20 years ago. It's called the global budget system. And the system was uh, adopted from Germany. Germany in 1993, they started for primary care physician service. They have the so-called global budget, the hard budget cap. So if the service volume exceeds what was projected, uh, the dollar value for each service rendered was discounted. And in Taiwan, we adopt the system to the whole services, including hospital services and everything. So we have running this global budget system for more than 20 years. And during these 20 years, uh, almost every quarter, when we calculate the discount rate, it's usually lower than 90 cents every dollar, sometimes lower, as low as 80 cents in some sectors, in some areas. So it's heavily discounted. Uh, as a result, any saving would not be true saving in dollar terms. Do you understand what I mean? Because the budget is set. So if you have any savings, which will be reflected in uh, in the discount rate. For example, if truly we save 10%, okay, and then we discounted the 80%, so now the discount rate will be becoming nearly 90%, but the money spent is still the same. So for 20 years, the budget is known every year. So there is no true saving, regardless of what happened. Have I made
Thank you.
myself clear?
Um, well, that was a question. I haven't seen the question re-asked, so I assume so. Thank you for clarifying the global budget. So another question, what do you expect would happen from yesterday's announcement that residents who go to academic health centers directly without referral would have to pay a lot higher copay?
Oh, I believe we have some audience read the news today or yesterday in Taiwan. the 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 new minister of health in Taiwan just uh, announced that he is going to raise copayment if people do not uh, do not seek referral first. And for 30 years, we have failed to implement the referral system or a gatekeeper system. So people are free to go to any medical center. Uh, many experts see this as a problem. Okay, uh, but uh, but in our National Health Insurance Act, from day one, we have a very strong article that says if you go to medical center without referral, you need to pay 50% of copayment. But beginning day one, no government has the courage to implement this part of the legislation. And no, the Congress has never challenged why we don't implement this. So for 30 years, we lived happily until today. A new minister seems to be determined to put this article in action, and many people do support, and you will be surprised. The doctors, the medical doctors, are one of the major supporter of increasing this co-payment system because they think people are abusing the system. So it's very different from what you would observe in other countries. So we will see what happens, and 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 um, and and basically what we need to see is that if nothing from the media came up to challenge the new minister, he probably would have this once in a lifetime opportunity to put his article into practice. So we'll see what happens. It's a very interesting and very bold action by the new minister.
We shall see.
We shall
Another
see, yes.
question. Yes. Given the rapid aging of Taiwan's population, how do you think NHI should adapt its contribution and risk pooling mechanisms to maintain equity and sustainability as the dependency ratio rises? And related to that, do you think Taiwan is drifting towards a two-tier system, given that it was started one way and now 70% is enrolled in voluntary private insurance?
Yeah, this is a very important and critical question. Actually, during my tenure in NHI, the health minister was Professor Li Minliang, who was later famous because of the SARS epidemic. He was the commander in chief and helped control the epidemic. He actually asked this question 20 years ago. He asked many, many experts, including Professor Shaw, Professor Reinhardt, and European experts. And uh, it did not have an answer. He said, "Are we moving to two-tier system?" And recently, I'm going to make another talk in Taiwan. That I said, you don't need to worry about that. We are already in two-tier system. So two-tier system is already status quo without a deliberate policy action. People just do it themselves. So that's one thing. And I think that for better, uh, how to finance it, your first question, I believe Professor Rachel Liu, who just did a report for the NHRI, which is equivalent to US NIH, NHRI's forum, they just produced a report. It's also in Chinese, I believe, only, uh, about how to supplement the NHI. So she proposes that perhaps we can put a second tier above this current NHI, since people are not willing to pay into NHI, and because we cannot let the young people to subsidize our baby boom generation anymore. We have all the assets at our hands, and they are working so hard. So the second tier seems to be a solution. Uh, uh, so so I don't have time to explain her concept of second tier. So uh, if you are interested, you should read the report about how to put in. So I personally, I do believe that official second tier uh, voluntary supplementary insurance, and which is a different structure than NHI. It perhaps is one way out of our current situation.
Thank you. So, another question relates to traditional Chinese medicine.
Mm-hmm.
The attendee asked, do people in Taiwan use the TCM and lots of wellness health products? Is that covered by NHI? And can you discuss how that relates to other parts of the benefit package?
Taiwanese people use lots of TCM and other, dietary supplement or health products. But health product in itself is not covered under NHI, but TCM is. Okay. So lots of people go to see a traditional Chinese medical doctor, and they are reimbursed. for the service and also for the prescription that they give. Uh, and most of the prescription, the Chinese medicine now, we call it the scientific traditional medicine, which means that we made it into modern dosage forms. So we reimburse the modern dosage forms. And if you really want to use the traditional form, that means that you buy those herbs, Chinese herbs, and go home and cook yourself. You need to pay for yourself. So we have this very interesting system for quality control. But yes, we do reimburse all the Chinese medicine officially approved by TFDA. But the other health products are out of pocket.
Thank you. Another attendee question. Why does the gap exist between high individual willingness to pay and low collective willingness to pay? Maybe you could elaborate on that point.
Oh, you mean that's like what I'm saying is just observation that people after I wrote these two books, I had lots of opportunity to talk to people, business leaders, public health experts, uh, healthcare delivery professionals and managers and many people. So I get the feeling. I ask them, especially doctors at the front line, especially oncologists. I ask them what happens. So they are saying that people, because they have private health insurance, so they are not worried about paying for new drugs, new medical devices, which is more and more often not covered by NHI. So they are not complaining and they are not worried. That is why I said that automatically it's always a two-tier system, and they oppose any increase in premium, which is paying into the common pool. Okay, so this is what happens especially during the previous 20 years. And the younger generation, we have a product that you can buy your children from day one, from at birth, and pay for 20 years, and then you can enjoy this coverage for life. So there are lots of products which now the commercial insurance companies, they are complaining that they did not expect the new technologies coming so fast, and NHI is not covering. So 20 years ago, because we cover almost everything, and the new technology is not so fast, they think that the future is rosy, but now they see the downside. So nowadays, many of the policies are no longer available. So this is a changing dynamics. So that explains, because the younger generation, uh, most of them are healthier, and their risk is low. So they are not convinced that they need to contribute into this social insurance. So that is why I say that you know uh, individual willingness to pay is high, and collective willingness to pay is low.
Thank you for that clarification. A final question about workforce. An attendee's asking about concentration of workforce in urban areas, or if there's any regional imbalance in the physician workforce, and if the NHI has any additional payments or incentives for doctors to work in underserved areas.
Let me give an extreme example, which was also done during the first 10 years. We implemented the so-called IDS. It's a borrowed term. It's called integrated delivery system in a remote area. So it's the most inaccessible because of physical distance in the mountains and the offshore islands. in every small tribes, we call it originally 部落, originally because they are Aboriginal, they are hunting and they live in the mountains. So they have this small cluster in the mountains. So these are not very accessible. So in that the so-called their tribe center, we will send doctors and sort of live there. Okay, we set up a health station, 24 hours service, and the doctors, they are from a hospital in in the nearby. So it's in the hill foot, mountain foot. It's not in the mountains. Usually in the mountains, it's very difficult to build a hospital, but there are very good health stations, very good equipment. If you come to visit Taiwan, you'll be surprised in that remote area. We have fully equipped with telemedicine equipment, and doctors and nurses serving 24 hours a day in this remote area. So yes, we subsidize because the operation cost for them is very high. But at the other opportunity, people ask me how expensive it is. It is actually not. If you think of most of the expensive payments are hospital care, are procedures, and also these new drugs and medical devices. Actually, providing service to uh, this remote area is not that unaffordable. During my term, I believe the cost comprised about one uh, 0.1% of my total budget. So it's negligible. I often share this story that if you have a single payer system, you can subsidize. You can subsidize these remote area and with minimal cost. It's not cost. If you design the system well, it doesn't cost you much. So I give this example to explain. And Taiwan is a very small island, so because the highway system and rail system is very good, so it's very difficult to think of nowadays a place where you cannot have access to a decent hospital within reasonable, travel time, safe, 30 minutes or 1 hour.
Thank you. So, do you have any final thoughts, maybe from your two books that you have not yet shared with us in the last few minutes?
Thank you, thank you. Well, the first book is about the left hand side is about. I think by 2030, if we don't do something, so it was written in 2020. At the time of the COVID-19, I actually said that if we don't do something quick, the system will bankrupt by 2030. It's kind of a doomsday prediction. And the second book is written in 2023 because after the first book, I think my assumption was wrong because because it's been long time that I truly you know um, uh, so working so closely with the system I was in. The previous 20 years I was in biotech industry. So there is a distance. So after that book, I learned a lot, and I said, "Oh, the crisis is not NHI itself. NHI is protected from bankruptcy because of global budget. The crisis is on what I just shared, on the labor forces, on the next generation, the younger generation, on the long-term sustainability." So that's what the two books are for. And these books are for the layman's. So in Chinese, it's quite readable. It's like stories. Okay,
No
thank you.
plans to have them translated?
And you can ask ChatGPT to do that.
Right, right. Okay, well, one final question from our guests. Do you have any advice for us here in the US? Any lessons you think we can learn from Taiwan's experience?
I don't think so. Well, I'm watching Major League, and at one time I actually shared this story in the U.S. when I was invited to give a talk on Taiwan NHI, and I started by saying that I'm very surprised that there will be any audience in the U.S. Want to learn from other countries. Okay, and I use a slide, World Series, because I studied in Boston, so that was the Red Sox against the Yankees. I said that you are playing World Series in America. Okay, so the rest of the world does not exist. but but I said, but you have the best players from the world. So your major league is actually World Series, which, but you don't, yes, you recruit talents and create your own system, but I don't think you will learn from other people. Other than that, the PBS, they did the front line, but I don't know how much people would watch it.
So no other advice that you can share for other
I
countries
don't
that
know
we
how
can
to
learn?
advise. The U.S. system is so complicated.
Every system is different. Yes. Well, thank you so much for sharing your wisdom with
Thank
us
you very
today. We
much for
really
inviting.
appreciate it.
I'm very, very, very honored. Thank you very much. Bye
Thank
bye.
you all for joining. Goodbye.
Bye bye.